It's time for the Kim Hammer Show, where you'll learn how your state government affects you, your family, and community. Here's Kim Hammer.
Good afternoon. Welcome to the Kim Hammer Show here on 101.1 FM The Answer. Glad to have you joining us on a beautiful Saturday afternoon for this time of the year. It's actually pretty mild, so we hope that you're out enjoying this beautiful day. And thank you for taking time to join in. I think you will be very happy that you spent time with us here on the Kim Hammer Show. You'll certainly be better educated when we're said and done, more informed about one of the more ongoing events that we're dealing with in society today, and that is the COVID-19. Let me begin by thanking my sponsors and also a little housekeeping that the opinions expressed and shared on the show are mine and mine alone, along with my guests. No reflection on the radio station, but we do appreciate the opportunity to be able to have this airtime with you. So I want to thank the sponsors, the folks that make this possible. That would be Everett Buick GMC Buick down in Saline County there on Highway 5 Elko Road. As I always tell you, and the story is consistent, and that's not a bad thing. Because you want consistency, especially when you go make a major investment of an automobile. And Everett's will take care of you down there. They've got a good selection still, and also they've got great service. You can get in and out quickly. They got a great place for you to lounge while you get your car worked on, and they can take care of you from every perspective of your automobile needs. Then Edwards Food Store here in Central Arkansas, also over in East Arkansas, as I always tell you, and they're consistent too. The stores are always clean, well-stocked, prices are competitive, meats are great, and all the produce are fresh, and you don't have to worry about finding anything you don't want to find in the produce section over there. So it's a great place to shop at Edwards Food Stores here in Central Arkansas and over in East Arkansas. And then, as always, for your real estate needs, Baxley, Phillips, Mouty, they can take care of all your needs here in Central Arkansas, whether you're looking to sell or whether you're looking to buy, and that's on the commercial or residential side, either one. And they can also take care of you on the rentals, whether you want to rent property, either commercial or residential, or you have property to rent. They can take care of you, and just give my friends at Baxley, Phillips, Mouty, there at Spring Hill and Highway 5 in Saline County a call. They can take care of all your needs here in Central Arkansas. Tomorrow at noon, we'll continue to air the service of the church that I pastor, Saline Baptist Church down in Tull, outside of Benton. You can tune in at noon here tomorrow for the delayed broadcast, and welcome you to come and worship with us on the Lord's Day tomorrow at noon. All right, we're going to get right into the show because we've got a lot to discuss. I've got a very special guest joining us all the way from the state of 10,000 lakes, I believe it is, Minnesota. I have on the air today State Senator Dr. Scott Jenson. And Dr. Jenson, thank you for joining us on the Kim Hammer Show today.
Well, thank you very much, Senator Hammer, for having me on.
Let's start off just, and usually I do this whenever I have somebody that is a physician or in the medical field. Just tell people a little bit about your credentials as a physician, how long you've been practicing, if you have areas of specialty, just something that gives people an assurance that you just didn't stay at a Holiday Inn Express last night.
Thank you, sir. Yes, I grew up in a small town in southern Minnesota named Sleepy Eye. And I went to public school, and then I went to the University of Minnesota and entered dental school and was president of the class in dental school, but found that I didn't really like teeth so much. So I made the logical move and went straight over to the seminary in St. Paul at a Lutheran seminary. And in that year, I made two big decisions. One, to ask my girlfriend to marry me, and we've now been married 42 years, and also to go into medical school. So I went into medical school and graduated from med school in 1981, and I've always been an active practice family physician. I've been a professor, associate professor at the medical school in University of Minnesota, Minneapolis, and now I presently practice at Catalyst Medical Clinic, and I started that clinic in 2001, and it's a primary care clinic that focuses on, if you will, pediatric, general family, and senior care. I did a Bush Fellowship in plastic surgery and dermatologic surgery in 1997, so I do a lot of lumps and bumps and melanomas and basal cells and squamous cells, and so skin care is a big interest of mine. But I also have a lot of patients that have grown older with me because I'm 65 years old, and so I've been taking care of the same people in Watertown for 35 years. That's really what I do now. And in Minnesota, when you serve in the Senate, it's considered a part-time job, so I still practice medicine full-time, and we generally have our sessions from January through May, and then from May to December I practice probably about 50 hours a week, and then during the session I'm only able to put in about 10, 15.
Okay, we lost you for a second, but we got you back. So we're kind of familiar. I mean, as far as our state legislative bodies, we are in equal comparison. We are part-time legislators here, even though it's really full-time effort if you put forth the effort to be full-time and do due diligence. And we also have a couple physicians, actually more than a couple, but two that come to my mind are Dr. Lee Johnson and Dr. Cloud. And so they can relate to what you go through. And I've always admired people that are physicians, but also serve in the legislature just because of the demands that are on your time. You're really working two full-time jobs, honestly, if you're doing your constituents and doing your patients right. Now, you are also a Republican, is that correct?
Yes, I ran as a Republican, and in 2016 was elected, and was gratified to earn more votes than any other state senator Republican. So that was sort of a nice little honor that they announced early on in my first term, was that I'd obtained more votes than any other senator in the Republican caucus.
Very good. Well, what that would tell me is you're respected. So that's a good credential to have behind your name as well. So let's get right into the meat of the matter and just ask, first of all, you've kind of gained national prominence here as far as being called before the Minnesota Medical Board. What exactly was it that you were called in front of the medical board for?
In Minnesota, the Board of Medical Practice has a pretty wide range of complaints that they deal with. And there were 2 complaints submitted against me sometime in the months of June and July, I guess. I wasn't given the date, nor was I given the names or any information regarding my accusers. But the first one said that in a news program with Chris Berg on April 7th, when I protested what was happening with the completion of death certificates, that I was spreading misinformation. And the second allegation was that because I was willing to make comparisons between COVID-19 and influenza, I was providing reckless advice.
Well, where are you right now as far as that matter is concerned? Is it ongoing still that you're battling with them, or has it been resolved, or what's the status of it?
I received a letter from them on June 27th, and in about 8 days I had submitted my response, which was a 5,000-word, 8-page response with 70 pages of attachments indicating that I was not guilty of either allegation. Comparing COVID-19 and influenza makes all the sense in the world, because it would make no sense to try to compare COVID-19 to tuberculosis or leprosy or shingles or gonorrhea. It's most comparable to a respiratory virus such as influenza, and they're both single-stranded RNA viruses. Dr. Fauci and Dr. Mike Osterholm and many highly regarded epidemiologists, scientists, and virologists around the country compare influenza and COVID-19 in order to provide people with context of understanding. In regards to spreading misinformation in the completion of death certificates, this also is a false allegation, because the Minnesota Department of Health made a wrong move when on April 3rd, they sent me an email telling me that it would be okay if I identified as the cause of death patients who may not have had any laboratory confirmation of COVID-19. There may never have been a test ordered. There may not have. But if I assumed that it was reasonable to diagnose COVID-19, I could put that as the cause of death. And that's just not the way death certificates are funded. A death certificate is a very precise document in that it should reflect a physician's best thinking in terms of what was the initiating event that started the sequence of causation, ultimately ending in the patient's death. And the idea of being able to assume that it was this without ever having tested for it or even considered testing for it, or simply utilizing it as a cause of death if it did nothing more than just contribute, that also, these were bad pieces of advice, because contributing conditions can be listed on a death certificate, but not as the cause of death. There's a separate place to put contributing conditions, so that if a person dies of congestive heart failure, but they also had diabetes, which had really made them susceptible, then you could put diabetes in a contributing condition box. But the bottom line was the Minnesota Department of Health, if you will, distributed this ambiguous advice, and a week later, after I protested, they sent out another communication clarifying things, and then 3 weeks later they sent out another clarification with a video attached.
I've got to ask you, just because I probably got guests that are wondering, are you riding a train or are you driving?
I'm driving.
Okay, sounds like a train. So let me just tell our guests, if you have a question you'd like to ask the doctor or like to have asked of the doctor, you can call into 501-823-0965, 501-823-0965, or if you're watching us live on Facebook, you can send it in, and Ben over here will get the question. We'll get it before the doctor to ask him. So, Dr. Jenson, we've had a lot of conversations here in the state of Arkansas. In fact, we've had several long health meetings, which I sit on the Public Health Committee, and the question about the death certificates has been raised. Now, as we understand it, and I'm not sure what the parallel differences or agreements are between your state and our state, but as I understand it, the CDC has actually sent out guidelines as far as how deaths are supposed to be recorded with regards to anything associated with COVID. Is that your perspective and your understanding from the state of Minnesota?
Yes, it is. And the CDC 7-page guideline regarding COVID-19 was linked to the Minnesota Department of Health communication of April 3rd. And the CDC guidelines were poorly done as well. And they flew in the face of the CDC manual for physicians as to how to complete death certificates. Death certificates are a big deal. CDC has probably a 25 to 50-page manual as to how to do it. And so I looked at that, and quite frankly, in the CDC physician manual, it identifies that we should focus on a sequence of causation, and we should always be looking at that initiating event, and that would be the underlying cause of death. So when the CDC put out their 7-page guideline, they also, if you will, undercut their own standing professionally. But they also have come out with clarifications now, and I think in large part because they realized that they had just made something that had been fairly clear pretty murky, and it begs the question, why would they do this? And so we've had a lot of flip-flopping, and the ironic thing was that the Bible for coding diseases indicated that if you have possible COVID-19, but you don't have a positive test, it indicates clearly that you should utilize a diagnostic code that reflects the symptom that makes you think about COVID-19. For instance, if you have fever and cough in a 50-year-old patient, so you're wondering, could this person have COVID? You don't put down COVID as your diagnosis code. You put down fever, and that has its own ICD code, which is character, and you would say diagnosis you would use until you received a laboratory confirmation of a test. Then you would use U07.1, which is the ICD code, the International Classification of CDC muffled. I think the chaos around the country, why was Pennsylvania subtracting 200 COVID-19 deaths from their count, Colorado doing the same, just within the last week, Kentucky has done the same. And then we saw New York go the other way, where New York said, gee, we've got this increase in deaths during this time frame in April that we don't know why that would have happened. So that must have been undetected COVID-19 disease. So they went ahead and a huge number of people, 3,700 people, to their COVID-19 death count. It went from 7 to 10,700 because they just assumed that these were COVID-19 deaths but they hadn't been detected. And these would have been cases where there hadn't been any testing confirmed.
All right, and we kind of, you're dropping in and out a little bit there during the last time, but in essence, what I heard you say was that based on the CDC guideline and the murkiness of which they originally presented them, it caused some of the confusion or some of the conclusions as to how death certificates were actually recorded. Do you think it would be worth Congress going in and taking a look and doing a deep dive into the death certificates to see if the numbers have been exaggerated or the deaths have been, for lack of a better term, misdiagnosed or mislabeled, so we could arrive at what is a true death rate 100% attributed to COVID?
I think it would be, and the biggest reason I think so is because in Minnesota, once I had sort of run this concern with the flagpole, the Minnesota Department of Health came out and said, we are not going to count anything as a COVID-19 death unless we have laboratory confirmation. And I think that's the right way to do it. But like I said, New York isn't doing it that way. So having said that, I think that if we would have Congress do that, we would have more reliable data. And some of the data may well drive the allocation and distribution of dollars from the federal government to various states, depending upon how much COVID-19 death and disease activity they had. We're already seeing some jockeying for position on the part of U.S. senators and congressmen trying to state that, well, we as a state should get more money because we've had more COVID-19 deaths. The first round of dollars distributed in the CARES Act was distributed based on the historical distribution of Medicare dollars to the states on an annual basis. That distribution has been criticized by some states, specifically New York and New Jersey, some states' representatives or congressmen, because they feel like they were more stressed by COVID-19 than other states. So we know it's going to have a real impact on dollars in distribution. So if that's the case, we certainly want reliable data. But even more importantly, we do not want to see the year 2020 be a year where all of a sudden heart disease deaths drop dramatically, and not because it was real, but because everybody simply was assigned a COVID-19 cause of death. Same thing with colon cancer. As a physician, I make decisions in terms of where we're going to put our initiatives and our efforts and our energy based on what is the cause of death for my patient population in my service area, in my state, in my country, in the world. These numbers matter, and it should not be trivialized, nor should it be messed with.
Let me cut in for a second, because you're talking about the funds that are going out to states based on the COVID death. I've got up on my website for the listeners, if you want to go up and check it out, at thekimhammershow.com. We posted last night an article from Becker's Hospital Review, and in the Becker's Hospital Review, it will show you how many dollars per death each state receives. I think Arkansas is like $285,000. And if you look at the, and that's loose paraphrase, so read the article to get the in-depth discussion. But what you just said is true based on what they put out in their review, because I was surprised New York gets less dollars, and somehow it's tied into the Medicare reimbursement, and I'm sure some formula, but it's all over the place as far as the states and how much money they get.
Well, Senator Hammer, I would assume that if you look at New York's number, it's probably going to be closer to $15,000 per COVID-19 case, while Minnesota's number would be closer to Arkansas's.
Yeah, and I'm getting Ben to pull that up, and I'll just give that out. But if you're listening on the radio or Facebook, you can go up there to thekimhammershow.com and pull up that article. It's on the front page, and read it. So, Doctor, let me tell you how I understand the process of getting a death certificate formalized, and here in Arkansas. Tell me if it aligns with you. So, we've already talked that you got the CDC that actually passed out the guidelines for the COVID, but the pronouncing physician, or even if it's a hospice nurse in Arkansas, if it's a hospice nurse, they can pronounce. And when they send in that death certificate originally, if it's a COVID-related death, it is coded as a COVID death. Now, that can be either primary cause, for example, like you're a 35-year-old, young and healthy, no history, and boom, you get COVID and you die. That'd be COVID primary. But if you have other underlying factors like diabetes or, heart condition, pulmonary issues, whatever, it could be the primary, but the secondary cause is going to be associated with COVID. So that puts all those listed as COVID deaths. Then it goes into the state health department who does a review, but it also goes up to the federal level. And I guess that applies to the COVID, where they have jurisdiction, I guess, to come back and change the original pronouncing physician's determination of the cause of death. Is that the way it works in Minnesota? Or what are your thoughts as far as that process, especially if an underlying cause is classifying that as a COVID primary death?
In Minnesota, we are not diagnosing COVID-19 deaths as COVID-19. We're not classifying a death as a COVID-19 death if the underlying cause of death is not COVID-19. In other words, if I have a patient that has congestive heart failure and they go on hospice because they have end-stage disease, and while on hospice, they continue to deteriorate, and it's apparent that they've got a few days left to live, if that, and they've said their goodbyes and the family's there, and perhaps in the last 48 hours of life, they're identified as having COVID-19. We are not, and then the patient dies, we would classify that underlying cause of death would be congestive heart failure, and we would not put it as COVID-19. We could put in the contributing conditions box, part 2, COVID-19, but that would not be called a COVID-19 death.
Okay. And for those numbers a while ago, Arkansas is 285,000, Minnesota is 380,000, and New York is only 12,000, which when I saw that, I agree with you. I was a little surprised by the numbers. What is the reason for the differences in the numbers as far as reimbursement to the states?
Well, let's go back to 2018. In 2018, across the land, Medicare paid out dollars to all the states based on the number of Medicare patients that the states took care of and what the charge levels were. So if I'm taking care of a patient and I end up doing a CAT scan and I end up doing an office call and it came to $500, that would be $500 that would go towards that total. So every state has its own, if you will, column with Medicare. And for instance, with 50 states, if everybody was the same, each state would be 2% with 50 states. But it's not that way because New York has a lot more people than Wyoming does. And in Minnesota, we don't normally hit 2%. We're about 1.7%. So when you multiply all the dollars that Medicare paid out in 2018, Minnesota's numerator over the denominator would be 1.7%. That's the formula that was used to distribute the first tranche of dollars going out with the CARES Act. So that Minnesota got 1.7% of, I don't know if it was 30 billion, I can't remember how much was distributed. Regardless of how many COVID-19 deaths Minnesota had. New York got its allocation, and I believe New York's allocation was somewhere between 5 and 10%. I'm going to guess somewhere around 7 or 8%. So if you multiplied the total that was paid out by 8%, that basically New York had 8%. So when that first tranche of dollars went out, they multiplied 8% times that, and that's what New York got, regardless how much COVID-19 death hit. Well, they had so many COVID-19 deaths that if you divide the amount of money they received by the number of COVID-19 deaths, it comes to $12,000. Minnesota had so few COVID-19 deaths that if you divide the amount of dollars we received, even though it was a lot less than New York, still it would come out to be $380,000 or whatever number you quoted.
How many deaths have y'all had in Minnesota?
1,550 approximately. 1,200 of them have been in long-term care facilities.
Okay. And with regards to the number of active cases you have right now, do you know how many active cases y'all have going on?
Well, in terms of hospitalization, we've got 250 in the hospital with 110 in ICUs. And in terms of cases that have not been, quote, identified as recovered, we probably have, out of our 50,000 cases total, we probably have somewhere around 5,000 that have not been pronounced recovered.
Okay. So I need to take a break. Can you hang on and we'll go to, can you hang on till 1 o'clock and finish the conversation?
Yes, I can.
Very good. All right. This is the Kim Hammer Show, and I have as my guest, Minnesota State Senator Dr. Scott Jenson. He was called before the Minnesota Medical Board for questioning regarding death certificates and how they're recorded with COVID, also which changed the number of the deaths. So I want you to come back after the break, and we'll pick up this conversation, and we're going to talk about contact tracing, and we're going to talk about moving forward and some other subjects. So come on back to the Kim Hammer Show after break. Thank you to Everett, Buick GMC, and Edwards Food Store and Baxley Phillips Mouty for making the Kim Hammer Show possible. We'll be right back after about a 2-minute break.
Take The Answer with you anywhere with our free mobile app, 1011FMTheAnswer.com, your smart speakers, iHeart, or radio.com. Breaking news and stimulating talk. 101.1 FM, The Answer.
Salem Media Little Rock just keeps getting better. If you're looking for some soul-lifting inspiration, check out 103.3 and 105.5 Rejoice, Little Rock's gospel experience. If Bible teaching is what you want, we've got you covered at Faith Talk 99.5. 93.3 The Fish is your home for real life, real hope. And our 101.1 The Answer is now the home of Rush Limbaugh. We're Salem Media Little Rock, the best in radio.
Do you have an IRA, 401k, or other tax-deferred retirement account? You want to think of this as being your money, right? But it's really a joint account between you and the IRS. Learn how you could dramatically reduce or potentially eliminate your taxes in retirement. Don't miss the David Lucas Show, Saturdays at 10 a.m. and Sundays at 2 p.m., right here on 101.1. The Answer.
Sean Hannity explains Biden's run to the left.
Now Joe Biden has done something that very few candidates do, and I think it's the biggest sign of weakness. He's now had to, instead of running to the center, having the nomination, he's now running to shore up what is the most radical base of this new Democratic Socialist Party.
The Sean Hannity Show. Afternoons at 2, right before Jay Sekulow at 5 on 101.1 FM. The Answer.
Hi, this is Gordon Deal. Join me weekdays for This Morning, America's First News. Hear the stories you'll be talking about and searching for all day as we go beyond the headlines and above the chatter with your first look at breaking news, money, Washington politics, technology, entertainment, entrepreneurship, and sports. We explain why stories matter. That's why we are referred to as the most important and relevant radio program. Join us weekdays for This Morning, America's First News.
There's no better time than now to start looking at your health, life, dental, vision, Medicare supplements, and options for long-term care insurance. Every few years, we all need to evaluate our coverage and look for the best coverage and rate. Art Wilborn Insurance is an independent agent that is contracted with several insurance companies and able to provide more options for coverage for you. He has a support team with 30 years of experience and is local to Central Arkansas. Give Art Wilborn Insurance a text today at EASY to 474747. That's EASY to 474747.
Good afternoon. Welcome back to the Kim Hammer Show. Thank you for joining us here on 101.1 FM The Answer. If you're watching on Facebook Live, thank you for joining us this afternoon. Again, I want to thank my sponsors, Everett, Buick GMC, down in Saline County, Edwards Food Stores here in Central Arkansas, over in East Arkansas, and in Central Arkansas for all your real estate needs, Baxley Phillips Mouty. You can go up on the website and check out their logos, and it'll take it right to their web pages where you can Check out all the services that each one of them offer. And if you are interested in advertising on the Kim Hammer Show, we are continuing to build our audience and our following. You can just send me an email to our website, which is thekimhammershow.com, and be glad to talk to you about advertising opportunities either on this show or up on the website. We will take good care of you. So we've got on the line Dr. Scott Jenson from Minnesota, the state of 10,000 lakes. And just out of curiosity, Dr. Jenson, how many of those 10,000 lakes have you gotten to?
Oh, I suppose 200.
It is a beautiful state up there. I was raised actually in North Illinois, and our vacation was to go up through Wisconsin and up into Minnesota and then on up into Canada. And, you know, Minnesota is a very beautiful state, so you're blessed to live in a beautiful part of God's world.
Thank you.
Now, you are an actual practicing physician still, correct?
Yeah, on the average, I probably see about 20 patients a day.
Okay. And I think that brings a perspective as far as dealing with the reality of, and you have the unique ability to be on both sides of the issue as a practicing physician, but also as a legislator who is involved in the processes of the laws that are made, but also the involvement of how the money is being spent at the state level coming down. I think that gives you a very unique perspective. Let me just ask you, as far as the money, if you don't mind, the money that you've received as a state in that initial wave, what are some of the areas that y'all have dedicated some of those funds to?
Conflict, because we have a divided legislature. We have a Democratic House of Representatives and a Republican Senate, and the governor is a Democrat. And so the Republican Senate was interested in working with the governor to decide where this money would be spent, and the governor was not really interested in our help. So it's really been driven by the governor, and it's been difficult to follow the money. It really has, because I think it's up, it's 1.8 billion, but we've certainly spent a fair amount of money on personal protective equipment, and we spent, which I think we'll find out that the ventilators never even get unpacked, because the standard of care in terms of taking care of someone in an ICU with COVID-19 is certainly not nearly as aggressive to use a ventilator as it was in February, March, and April. And I think we've seen some real frivolous expenditures in Minnesota. Our governor spent $7 million to purchase a big building that he could repurpose into a large refrigerated morgue so that we'd be able to stash the bodies that would be coming from the COVID-19 pandemic. And Governor Walz in Minnesota had told us that we would have 74,000 deaths. And then later on, he established a different number and said, we will have 29,000 deaths. And right around then, I put a video out saying, I'm not buying the 74,000. I'm sure not buying the 29,000. Then he came out with a model that said that we'd have almost 1,000 deaths per day in the middle of July, which is what we're in right now. And we haven't had double digits in deaths since before July 4th. So we have typically 3 to 5 or 6 deaths per day from COVID-19. We've had a total of 1,500. And yet Governor Walz's modeling had told us we would have almost 1,000 per day. And for this reason, we would need this morgue. And so we now have a building that was probably worth just about nothing. And we paid $7 million for it. And it really gripes a lot of Minnesota citizens.
Well, maybe that'll help you take the House and maybe take the governor's office someday. If you let them do enough damage, you can use it in the campaign. Let me ask you about this, because we were having a conversation in one of our public health meetings the other day about the baseline, because the question was asked, when will the pandemic officially be over and who controls that? And do we as a state have any latitude to say, in our state, the pandemic is over? The response that was given by the health department was no, that is a term that is actually owned and controlled and defined by the worldwide medical health organizations or the nation's medical organization. And tied into that baseline are the number of deaths. Given the fact that you have called into question, and we are calling into question down here in Arkansas, the deaths that are being reported, are they Are they true COVID deaths, or are they underlying deaths? What's the real number? Do you see that all these projections that have been made by various experts that are not shaping up or lining up are having a contributing factor to that baseline, or is there any correlation between the two?
Well, first off, the World Health Organization will be the organization that determines when the pandemic is over. And if you look at 2009, I believe that was about 15, 16 months. Many epidemics are oftentimes about 12 months in length. In terms of the COVID-19 death counts, I do worry that there's been a certain casualness introduced into the equation. And with that, we will have potentially, and I'm saying that potentially because each state has made their own determinations, but we have the potential to have an overstated COVID-19 death count. We also have a very real potential, and I think a likely reality, that we are undercounting our COVID-19 cases, because for every case that we have, there's numerous studies that have been done that would indicate that we probably have anywhere from 10 times that number of laboratory confirmed cases to even up to 100 times that number. So having said all that, I think these are the metrics that are driving the policy decisions as to lockdowns and how aggressive a state might choose to get with contact tracing, or whether or not they're going to have mandatory masks and decisions like this. And so these numbers are critical. And the American public is a savvy, engaged group of people, thankfully. And they're not buying everything bureaucrats, supposed scientists, and politicians are selling. And so they're saying, we think there may be some perverse incentives underlying what we're doing here, and we want this to be checked out. And that goes back to your earlier question, Senator, about should we think about having Congress do some sort of an audit to make certain that we really are comparing apples to apples.
Well, and that's, I've actually sent our our U.S. Senator a message a little while ago saying that I think that one thing Congress ought to do is look at the deaths and do, like you just said, an audit of the numbers with unbiased set of eyes looking on it to give us some factual information, because I think this thing hits so fast and it has become, I would not be surprised to see that there are some that are trying to utilize it to an advantage to draw money to their states through whatever means or mechanisms they have to have in order to be able to create more resources. And if that means you gotta tweak the numbers a little bit to make it happen, that's a pretty strong accusation. But I know if you got to tweak the numbers to make that happen, then that's what you do. And I think it's going to take, an independent assessment of the situation in order to arrive at that. Are y'all talking about doing anything like that at the state level up there, or are you just kind of waiting on the feds to kind of take the lead?
There has been inquiries made about having some sort of an audit done. I have asked that we think about auditing the modeling team that Minnesota has used, because I think we ought to have a critical analysis of where did we go right, where did we go wrong? Why did the governor think we were going to have 74,000 deaths when we ended up with, we haven't gotten to 2,000 total yet? But I think the feds would be in the ideal position to do it, because they're the ones who are going to be handing out the big amount of dollars. And quite frankly, the criteria for making diagnoses of COVID-19 are squishy enough that the concern you're expressing is a very real one. It may be a strong accusation. And I don't think that we're worried. I'm not worried about physicians fraudulently or intentionally, erroneously completing a death certificate or a discharge summary. I think that it's oftentimes you look at something and, well, is that light green or is that dark green? And it's oftentimes a situation where you can choose. I mean, I've been encouraged by hospital personnel at times to diagnose on a patient I'm discharging from the hospital, to put the first diagnosis as dehydration and the second diagnosis as diarrhea, because the hospital will get paid more. If it's diarrhea first and then dehydration, the hospital gets paid less. And in my way of thinking, I don't really care. All I know is that I had a patient that was dehydrated and had diarrhea, and we put him in the hospital, rehydrated him, got him better, and sent him home. But which one of the diagnoses we list first? To me, it's six and one, half dozen of the other. But that's the kind of squishiness that could allow one state to do it one way and another state to do it another, or one hospital system to do it one way and another hospital system to do it another way. And this is why I think that potential value of an audit would come into play.
Well, speaking lawmaker to lawmaker, one of the things I've got a concern about, and some others have begun to express it, is all this money has come into the state, and it's pretty much rapid fire sending it out. Now, I think New Jersey, I read an article that they are still holding back the vast majority of their money because what they're concerned about is how will the feds come in and regulate, and how will they hold the states accountable for all this money that we've been given. And any of it, if any of it, is tied into the direct number of cases that we've had or the number of deaths that we've had, that in a couple of years, you know, it could be payday someday that we would have to pay some of that money back because of the formulas or the projections or what we used as justifications at the moment to do with the money what we did, and the feds come back and say, no, that's not right. Are y'all getting any of that concern expressed up there?
Not a great deal, but I think that there has been an intentional effort to hold back spending some of those dollars. But in terms of in Minnesota, I think because we're not counting COVID-19 deaths without laboratory confirmation, we believe that we're sort of on solid ground. And I think that's going to matter.
Well, let me ask you, because we had this conversation in the meeting the other day, and I didn't get all the way down in depth. So let me ask you, as a physician, if a person dies and they have been tested for COVID-19 and they have been found to be positive, regardless of whatever other causes there may be associated with that death, whether it be pneumonia or whatever, in Minnesota, do you list that as a COVID death?
No, we don't.
Okay. And do you do any testing after a patient has died to determine if they had COVID?
I don't know the specific answer to that. I presume that we are. I mean, if we come across a body that's perhaps, if you will, still warm and dead, it's certainly easy enough to go ahead and swab the throat and the nasopharynx to see if COVID-19 was involved. I think that there's been a push by medical examiners and coroners to get as much information as we can. So I think that that's happening, but I could not give you a specific, example of that. But I know that in Minnesota, if we have someone die of a car accident, we're not going to put it down as COVID-19 because they have laboratory confirmation.
Okay. Let's spend the rest of the time we've got. Let me ask you about contact tracing. What efforts are y'all doing in Minnesota for contact tracing, and what is your opinion as far as is it beneficial? In our meeting this week, the big discussion was the money that some are wanting to spend on contact tracing. The other side of the argument is it doesn't do any good to do contact tracing if you're not getting 1 day turnaround times with your test results. Otherwise, you're operating on outdated information. You may do something, but it's so far down the line, if your test results are coming back 7, 8, 9, 10 days later, that by the time you find out, it's pretty well a done deal. What's the conversation in Minnesota around those subjects?
Senator, you're doing a nice job of framing it up, and the concerns that you're expressing are exactly right. A couple of things that we would add in when you're talking about COVID-19 is because it's a disease that has a 14-day incubation period, which is that period of time from exposure to showing symptoms. And because it has a latency period, which is the time of infection to the time of becoming infectious, the latency period with this disease is shorter. So what that means is a person will get infected and then they will become infectious in many situations before they ever show a symptom. That is a very difficult disease to do contact tracing. in addition, the symptoms are so nonspecific. It's one thing if we're dealing with, if you will, Ebola, or if you're dealing with, if you wanted to try to do it with chickenpox or even measles. These diseases lend themselves more to contact tracing. We had the same contentious discussion because the governor's office wanted millions and millions of dollars to increase the contact tracing program. And the Republican Senate said, no, we are not going to spend the money there. We've got other needs that are greater than that. And so we went ahead and said no. And what we're allowing is the departments of health to continue to do what they've done in the past, which is doing limited contact tracing through phone calls and really trying to target some of those hot spots that might come up, whether it's a meat packing plant or a poultry production, something like that. But the idea of using Google apps to identify how close you've come to someone who is positive and things like that, we did not go with that, and we do not intend to. Contact tracing is a little bit of a slippery slope. You can relatively easily slide into a situation where you're infringing on people's rights to privacy. And we actually had the governor, at least in my eyes, we had the governor already violate the dissemination of private health information when he instructed with an executive order the Minnesota Department of Health to distribute a comprehensive list of all addresses of active COVID-19 disease to more than 500 law enforcement agencies.
That wouldn't go good.
No, so that if a first responder team was going out to a home on a 911 call with chest pain, that they would then know whether or not that address was on the list. And if it was, then they would know to take special precaution. The problem that's with that kind of thinking is that we know that for every identified address, there's probably another 10 addresses where there's active COVID-19, but it has not been identified. So we are conceivably lulling first responders into having a sense of security that they should not have. They should go in preparing and expecting the worst and perhaps hoping for the best. But this decision on the part of the governor was really problematic, and it caused the ACLU, the American Civil Liberties Union, to come against the governor, which was really odd considering that the governor is considered to be a relatively liberal governor, and the ACLU is typically taking positions alongside of liberal positions. And they came out and denounced the governor's decision. And I think this is all part of that whole thing about a government response going too far is a clear infringement on the rights of Americans. And you could even take that further and say, when the government says you are going to lock down and we don't care what you think, we don't consider your business to be essential, so you're a non-essential business, you're going to close your business. If that means that you are going to become unemployed and never be able to open your doors again, too bad. Maybe you can get a government handout someday. But these kinds of things are what make this whole pandemic so incredibly challenging, and this time around, so incredibly unique.
Well, and to that point, I think as conservative Republicans, that's the one thing we need to do as far as establishing what are the criterias that are being used to determine A, the deaths, and B, the measurable impact on us as a society, so as to not let this thing go to the overreach potential that it has. And that's a fine balance. You don't want to be conspiracy theory all the way, but yet at the same time, when you see the advances of the liberal left and what they're doing, taking advantage of this thing with, Antifa and all the other, you can't help but have to put up some safeguards to say, you know what, if they would do it in this area, they would like to do a little bit more land grab. And to me, that's always the concern that we need to exercise anyway in the process of making our decisions. Let me ask you, Doctor. I've got a question sent in by Emily, and her question is: are active cases simply positive test results, which would include the asymptomatic people and ones receiving treatment?
In many states, positive cases would basically be what Emily has just articulated. It would be those positive tests in people that either show disease or don't show disease. But if they have a positive PCR test, that would be a positive case. Then the question would come up, what about the person who never had a positive PCR test, but thought they might have had it at some point, and so had a positive serology where they have antibody test positive? Typically, many states will report that also as a new case, a unique case. But they would not want to count it as two cases if it was a person who'd had a positive PCR test and a positive antibody test. They should only be counted once. But in Texas, there was a decision in some areas to go ahead and identify probable new cases based on contact with a laboratory confirmed case, but no positive test themselves. So all of a sudden, the potential for positive new cases was enormously inflated because contacts would be included in this. And I think as long as we're talking about testing, I think one other thing we should share, because some of your audience might not be aware of this, Senator, is we don't just develop immunity to COVID-19 through antibodies. In fact, there's a recent study out of England that has indicated that they believe that for every person that has developed immunity to COVID-19 through antibody formation, there are 2 patients that have developed immunity to COVID-19 through cellular immunity, which is through the T lymphocytes. And so when we start to look at how do we hit herd immunity, we cannot rely simply on data that gives us antibody immunity, because there's at least another large chunk of people, possibly twice as large, that will have T-cell immunity, and there will even be most likely another group of people that have intrinsic disease resistance. Similar to, if you wonder sometimes why in the world that in the day that Jesus walked, why didn't more people get leprosy? And the fact of the matter is 90% of the population in the United States couldn't get leprosy if they put the germs on their cereal. We have a disease resistance, and we have that to many diseases. Black people are highly susceptible to sickle cell disease if they have both genes for the sickle cell, then they would get sickle cell. But if they only have one gene for it, then they won't have sickle cell, but they will have an intrinsic disease resistance to malaria. And this is the way our immune systems work, and this is the way natural selection works. So when we start to talk about how do we get to herd immunity, we don't necessarily have to get to 70%. We can think of antibody immunity, we can think of cellular immunity, we can think of disease resistance, because it would be fallacious reasoning to think that we're going to sit here helplessly waiting for a vaccine to be discovered and utilized. I mean, it'd be great if we had a wonderful vaccine, single dose, able to be used across the spectrum of population with virtually no risk and effective. But the likelihood of that is
Dr. Jenson, I've got to cut
Yeah.
you off. This is only a 1-hour show, and today I wish it was a 3-hour show, and I'm down to like 30 seconds, okay? I want to get you back on. I'll call you later. We'll get on a conversation to get you back on the show. My guest today has been State Senator from Minnesota, Dr. Scott Jenson. I hope you've enjoyed the show. Hope you share the show. Tell them they can go up to the video and watch it again. This is the Kim Hammer Show. Hope you have a great Saturday afternoon, and I'm really sorry that we had to cut off as short as we did, but I hope you've really enjoyed it because I've been very educated as a senator myself, and look forward to more conversations with Dr. Jenson. Y'all have a great day. This is the Kim Hammer Show.
101.1 FM, The Answer. KDXE FM, Kamak Village, Little Rock. A Salem Media Group station. 101.1 FM, The Answer.